Hi everyone. My name is Autumn, and for our group project, me and Kevin chose familial hypercholesterolemia.
Good morning. We're going to go over our familiar hypercholesterolemia. We did do a case study on this a little while ago, but we do have some new information for you. First off, what is familial hypercholesterolemia? It is a inherited condition in which plasma cholesterol levels are nearly twice, sometimes more than the average level in normal, resulting in an increased risk for heart disease and early heart attacks. Depending on the genetic variants, familiar hypocholesterolemia is characterized as a autosomal dominant hypercholesterolemia, which is ADH, autosomal recessive hypercholesterolemia, which is ARH, or polygenic hypercholesterolemia, per Adolphson and others in 2025. The presence of familial hypercholesterolemia is in two different branches. First, you have heterozygous, which is capital H, lowercase e, FH, which is the more common variant, 1 in 500 people. And then you have the homozygous, which is 1 in 1 million, and that come from Abifidel and Below in 2022. Pathophysiology of familial hypocholesterolemia. It is characterized by extremely high levels of blood, low density lipoproteins. That gives rise to extravascular deposits, such as tin and Skindon xanthelasmas. Um, Also, rings around the corneas called arcus cornealis. It causes progressive and premature atherosclerosis. It causes coronary heart disease, also cerebral arterial disease, and it increases morbidity and mortality per Abifidel and Below. Heterozygous is more common and more easy to treat. High dose statins generally prove sufficient. Per Warden Fazio Shapiro, patient with heterozygous familial hypercholesterolemia, we may see a 60% in LDL-C reduction. The homozygous requires more stringent medication and dietary regimens. It is more rare and it is more difficult to treat just because of LDL-C receptor resistance, and more prolonged LDLs in circulation. Poor Julia Rogers in our textbook, those with heterozygous familial hypercholesterolemia will have, excuse me, coronary vascular disease and MI prior to their 20th birthday. And historically, we have had infarcts as early as 18 months, which is astounding.
So, with FH, there are some symptoms that you can kind of keep an eye out for. So, these visible symptoms on the left, we have tendinous xanthomata. I'm thinking that's how you say that. But that is essentially just like these plaque buildup. and you can see kind of like little balls within the tendon. That's kind of what they look like to me. And then on the right is Arcus cornealis. So this is that blue ring that you see around the eye, and that would be prior to the age of 45. That is something that usually that you see in a lot of adults over 80, and that's definitely something that's more common in males. But those are some of the things that you can kind of see as a symptom of this. So, with the prevalence of this increasing, Melissa Austin, who's a professor of ophthalmology at the University of Washington, she worked to create the Dutch Lipid Clinic Network criteria. So, what this criteria does is it goes over a person's family history, clinical history, a physical examination, so looking for those physical symptoms like the eyes and the tendons, and looking at a cholesterol level on the patient. So looking at those, the patient would get a score, and depending on that score, it would determine if the patient would definitely have this hereditary disease, if they probably have it, if they possibly have it, or if it's unlikely that they do have it. But this gives people the opportunity to look at these symptoms and stuff like that to determine, do I need to get further testing or do I feel comfortable with where I'm at? But this also helps providers look into the symptoms that are presented to them and determine what their next step is going to be.
Genetic testing. Genetic testing, there are 4 distinct genes we look at in familiar hypercholesterolemia. That is the functional mutations of the LDLR, which is the low density lipoprotein receptor. That is the receptor that LDLs should join to, that they usually do not. Next, we have ApoB, which is apolipoprotein B. There is also an E variant, apolipoprotein E. And I'm probably going to butcher this, but it is our PCSK9, proprotein convertus subtilicin kexin type 9. This information came from the Adolphus Journal. One trend that is offered now is cascade testing. And the CDC tells us that cascade testing is the process of informing family members of a genetic condition discovered within the family. This is followed by family members receiving testing for the condition. This is not linked to just familial hypercholesterolemia. This could be any genetic type condition. What this allows for is it allows for patients with a known disease to get their siblings, parents, and even children screened so that appropriate treatments can ensue for their condition. This gets a head start on treatment, especially like familial hypercholesterolemia, so we won't have the sequelae down the road, strokes, heart attacks, peripheral vascular disease, things like that, to become an issue.
So now we begin to look at treatment for the familial hypercholesterolemia. So with treatment for this, that's going to be based off of which type they're presenting with. So first we go over the heterozygous. So that means that instead of having both genes for this disorder, they only have one gene. And that's generally the better of the two, the safer of the two. So this is one that is more able to be controlled with a diet. Statin drugs are usually like the first line for this disease. That's used to treat the high cholesterol levels and help the body learn to process it better. Usually, Lipitor is used anywhere from 40 to 80 milligrams daily. Rosuvastatin, 20 to 40 milligrams daily. And then The PCSK9 inhibitors that can help as well. They attach to the PCSK9 in circulation, and they kind of prevent it from collaborating with surface low density uh, lipoprotein receptors, and that helps to lower that cholesterol. And I'm going to say it wrong, but I'm going to say ezetimibe. That's how I'm going to say it. That would prevent uptake of cholesterol through diet and like cholesterol secretion in the bile. But those are usually your first line of defense with this heterozygous version. Alrighty, so now we have homozygous. So that means instead of just having the one cell, they have both. So this is usually the worst of the two. It's a lot harder to treat. So essentially your liver is what's going to process all this cholesterol and everything else, and they have seen good results with a liver transplant for these patients because medication is usually not as effective as it can be just because their body isn't working with it. There is also plasma exchange to try to keep the levels lower, and I've seen research looking into somatic gene cell therapy. And then there's mipomersen, which binds to human APOB mRNA's coding region, and it causes that to break down. So these are different options you have when looking at the homozygous version, but usually the homozygous is a little bit more lethal, and the outcomes aren't as good even with all of these treatments. Okay, so now we move on to morbidity and looking at, living with this disease essentially and the sickness that it involves. So with the morbidity of it, there is usually atherosclerosis, which is like fatty buildup inside of the arteries. And this fatty buildup can make the arteries a lot harder, especially in the brain and the heart, and that diminishes blood flow. So with that diminished blood flow, it can lead to heart attacks, strokes, ischemic attacks, and that diminished blood flow can affect your cognitive ability. There's even the potential for amputation. And this is all something that can be like greatly increased with diabetes and other comorbidities.
On now to morbidity and mortality. Morbidity comes basically from atherosclerosis. That can be cardiogenic in nature, be that coronary artery disease, which is diminished compliance and hardening of the arteries. That can be cerebral vascular disease, which is in the brain. That's leading to myocardial infarction. That leads to stroke, which is the more causative death with familial hypercholesterolemia. A study by Marco Beniti and al. It was a family study of 62 dead relatives among the heterozygous family members, 53 among the non heterozygous familial hypercholesterolemia individuals, and 100 controls. Shows the mortality rates between those with lipid issues and not. Inside this family, cardiovascular disease was higher within the hypercholesterolemia group, 59.7% as opposed to 37.7 and 37.4 in the control. CVA occurred in 7 individuals, which is 11%. 5 of the non heterozygous individuals, and 10 altogether. Cancers, mostly of a digestive origin, 35%. breast and prostate cancers of 29, lung cancer 22%. And what this study shows us is that the rates of mortality in family hypercholesterolemia surpass those without the condition. So, mortality causes were stroke, heart attack, and cancer. Digestive cancers can include colorectal, um, liver, pancreatic, stomach cancer, esophageal cancer. So, getting the lipoproteins under control makes the body work a little more effectively, preventing those atherosclerotic deposits, and it works out a lot better for us. And in a quick brief show of our
So with familial hypercholesterolemia, there are additional risk factors. So anybody of male sex is more inclined to have it, and that's especially prevalent in Ashkenazi Jews, Lebanese, and French Canadians, from what I've found. Smoking and alcohol use, basically anything that can be detrimental to your cardiovascular system and can cause more of that atherosclerosis and like plaque buildup, is going to be bad. Your liver is what's helping you process all that cholesterol. So chronic alcohol use, fatty liver, stuff like that can make this disease a million times worse. So watching your alcohol intake, trying to quit smoking, stuff like that can really help with this, especially the heterozygous version. Diabetes is also another big thing. And a lot of our techs, diabetes is one of the main causes for almost anything. But uncontrolled diabetes can essentially ruin your entire vascular system. So ensuring that you are keeping track of your blood sugar and taking your medications like you're supposed to, so that it doesn't cause further damage to your body and your veins and your arteries. That's really important with this disease because that can be detrimental. And the last thing on here is delayed treatment. So with this disease, a lot of people kind of push it off, but it's not something that you do want to push off, especially with the risk of heart attack and stroke and everything else. It's something that you want to get treated, because if treated early, you can, live with this disease. But if you let it go by, then you might not. So if we were in person, this would be the point where I would ask if anybody had any questions, but we're not. So these are the references that we use. Some of them are for the pictures and some of them are for the other websites. But we hope you guys enjoyed.